I previously promised to show how I assess the primary literature to try and keep myself up to date. And I don't recommend this to other people, but for those who are interested in systems, this is how I do it. I use Chrome as my browser. I have a couple of useful Chrome extensions, including OneTab. It enables you to collect a whole bunch of tabs and group them and store them. So when I'm reviewing journals, I might look at some critical care journals, pediatric journals, general and cardiology journals I've grouped together. I've grouped together emergency medicine and resuscitation journals and anesthesia and pre-hospital emergency medicine journals. So I have these journal review sets as tabs. And when I decide I need to catch up in one of these subject areas, I will open the whole group of tabs. So I'm going to show you how I'll review critical care journals. I'm going to restore all of these tabs and take you through them. So the first tab is my Google spreadsheet of the journals which I've read for the year, and down this column are the critical care journals that I like to review: American Journal of Respiratory Critical Care Medicine, Anesthesia and Intensive Care, and so on. I have each year as a block, and you can see I've reviewed some journals from January and February and even March and April, but there are some gaps that I need to address now. And when I review a journal, I will click the box and it will be formatted red, just with a conditional formatting formula in Google Sheets that ChatGPT taught me how to do. So I have these journals to go through in alphabetical order, and the tabs should have opened in that order so I can start going through them. A couple of other tabs I have are a library search. This is from NHS Scotland. Through one of my college fellowships, I have access to Open Athens. Many people in the UK will be familiar with Open Athens, and through NHS Scotland, I can use my Open Athens password to access full text of different articles. If you work in a hospital or are associated with a university, there's a good chance, if you're a healthcare worker, your organization will have some way of giving you full text access to many journals. But there's a lot you can get from just reading the free abstracts in terms of deciding whether something is potentially practice changing, and if it is, then visiting a secondary evidence source to get the lowdown on whether that paper applies to you. And I've got another video that shows how smart people use secondary evidence sources to keep themselves up to date, rather than spending many hours doing what I'm showing you here. And then I have a repository of papers that I download, which also provides reference management software. And I use Papers, which is a relatively inexpensive way of keeping all of my journal articles in the cloud, catalogued, tagged, and accessible from any device connected to the internet. This is well worth the money. So let's begin. Look, for January, I haven't looked to the Annals of Intensive Care yet, so I'm going to go to that tab here, and here's the contents list for the first issue of 2024. Looks like there aren't any others from 2024 available yet. So I would just quickly scan through the contents list and see if there are any articles I would like to explore further. So here there are risk factors for bleeding complications in patients undergoing ECMO following out of hospital cardiac arrest. I'm involved in pre-hospital ECMO at the moment, so I'm going to have a read of that. I'll open that article in another tab by pressing Control click or Command click on an Apple device, and off I go to look at the rest of the contents list. Prevalence and prognosis of hyperdynamic left ventricular systolic function in septic patients. That looks interesting. Pupil exams and prognosis in out-of-hospital cardiac arrest patients who had ECMO. Let's have a look at that one. I'll command click, open that in another tab. And now we've got to the bottom. So going to have a look at those two papers that I've opened. Here's the risk factors for bleeding complications. This is a Japanese study. They're usually quite big with lots of patients. There you go, 1,632 patients included, of which 361 had bleeding complications. What did they conclude in this large database study? Up to 22% of patients had bleeding complications requiring transfusion, interventional radiology, or surgical intervention. And the significant risk factor was an initial platelet count. That's consistent with things I've seen in other studies, that the platelet count significantly associated with bleeding complications. I'm not going to look at this study in any more detail because there's nothing particularly practice changing there. I'll close that tab and I'll look at the second article that I opened. The prevalence and prognosis of hyperdynamic left ventricular systolic function in septic patients. So the hemodynamics of septic patients are very interesting. and often oversimplified. In a young fit patient who's septic, you would expect and you'd think almost be reassured by a hyperdynamic left ventricle, wouldn't you? But this study has shown that there is significantly higher short-term mortality as compared to normal LV systolic function. Or is that just because they're sicker and they need a hyperdynamic LV, or is there more to it? This is a paper I want to read in some more detail, so I'm going to download the PDF and I'm going to read that later. So I've got to look at my downloads folder after this, so I'll close that tab. Now we have the pupillary examination in patients with out-of-hospital cardiac arrest who underwent ECMO, and this showed that those who had poor pupillary examination findings on hospital arrival, 10% had a favorable neurological outcome at hospital discharge. And a positive pupillary light reflex after the establishment of ECPR was significantly associated with favorable neurological outcome. What does this tell me? Again, this is another SAVE-J big study, 2,000 patients. This tells me that just like other cardiac arrest patients, there are still those who have poor pupil responses on hospital arrival that will go on to have a good neurological outcome. So you cannot use absent pupillary reflex to prognosticate on day one. However, conversely, patients in cardiac arrest who have been resuscitated who have a good light reflex, that is associated with a favorable neurological outcome, and that applies equally to patients who in cardiac arrest have then been established on ECMO via ECPR. I'm not going to read that one in any more detail. I'm going to close that. So we've now gone through the Annals of Intensive Care. There's one paper on hyperdynamic LVs in sepsis that I want to see in a bit more detail, and I can open that paper now, and if I have time I could read that now because I finished looking at Annals of Intensive Care, or I can go on and look at the next journals. But this looks like a paper that I do want to have a look at in a bit more detail. When I've read it, I will go to my Papers tab and I will drag that paper into Papers. It will import it and I can associate tags with it, which I've actually already done. So these are some of the tags I use for finding papers. Got echo, hemodynamic, vasoactive, sepsis. So if I'm doing a presentation on sepsis, then I'll open Papers and I will search by a sepsis tag. Or if I want to talk to people about vasoactive agents in sepsis or hemodynamics in sepsis, again, I can use tags to find the papers. So I really like this app, and again, it's not that expensive. All right, I'm going to go back to my spreadsheet, and that was Annals of Intensive Care. We've looked at January. I'm going to tick that off. Quite satisfying to get the little red block there. I've only got 2 journals left for January that I haven't reviewed. So we'll go on to have a look at chest. And you can see in 2024, there are 3 issues of chest that I haven't read. So I'm going to go to January. I'm going to whiz through the contents list of the January issue of chest. And you can see actually that some of these links have been looked at before. So I have actually looked at chest already this year. And you can see the kind of things I've been looking at. Cardiogenic shock paper there. Okay, so I have actually gone through chest already. So I'm going to click that off as done. And then we've got critical care. This journal publishes open access articles when they're ready. It doesn't categorize it into monthly issues. So to click it off for January, I'm not looking for a January edition. I'm actually looking at articles published in January. That's how I look at this one. So I'll go down to the first articles of the year in January and start going through all the articles from January. You can see I've clicked on this one before. So video versus direct laryngoscopy in critically ill patients, systematic review. I've actually accessed that one and read that paper before. So going up, looking for things that I'm interested in, or might be practice changing, or I want to tell my friends about, or I want to read about in some more detail. There's another ECMO related paper there that I've already clicked on and read. Another video laryngoscopy paper there. Steroids and cardiac arrest. I've read that one. Right, we've got an article on incidence, diagnosis and management and outcome of acute mesenteric ischemia. Really important diagnosis, can catch us out. So I'm going to control click or command click the PDF link there, so we'll have that paper open. And now we're on to February, so I'm not going to go through February at the moment. I'm going to look at this paper from January. So this is the one on acute mesenteric ischemia. They looked at all adult patients with a clinical suspicion of mesenteric ischemia at 32 participating hospitals. 705 included patients, of which 418 had confirmed acute mesenteric ischemia, which they're calling AMI. They've shown subtypes such as occlusive arterial AMI, which was just over half of them, 55%, venous ischemia, and non-occlusive mesenteric ischemia and unclassifiable in 11.5%. More than half got surgery, some of which got revascularized, and endovascular therapy alone was carried out in 13%. Some were conservatively managed and some were palliated. So the in-hospital and 90-day mortalities were 49 and 53%. So half of these patients die. Lowest mortality was in the venous AMI subtype. They do better. And highest for the non-occlusive mesenteric ischemia. 3/4 of those die. So if you've got mesenteric ischemia, but it's not from an occlusion, then it's from general hypoperfusion, so you're very sick. I imagine that's what's going on there. They reiterate that there is a need for greater awareness of acute mesenteric ischemia and better guidance in diagnosis and management. I find it an interesting topic because it's poorly recognized. There are often delays to diagnosis, and even when the diagnosis is suspected or confirmed, systems can sometimes conspire to delay definitive treatment, particularly surgery. Coming down to subtypes of acute mesenteric ischemia, the majority of cases of non-occlusive MI occurred during the stage due to another distinctive diagnosis, and most of these patients were being treated in an ICU setting. There you are, so they're generally sicker, as we thought. And patients with venous AMI were younger and previously healthier, but they have a higher rate of significant venous thromboembolic events. They're less severely ill at admission, but they have more elevated D-dimer levels. There's a table there. In the table, we've got D-dimer levels that were taken in 119 patients for the different subtypes and how it compares, because D-dimer is an interesting test in terms of mesenteric ischemia. It's got a better negative predictive value than lactate, which is what people often focus on. A raised lactate's important, but a normal lactate does not rule out acute mesenteric ischemia. That's really important to know. So this paper's got a whole bunch of interesting stuff, potentially not previously described or quantified, in a really important emergency medicine critical care diagnosis that I would like to understand better. So I think this paper is great to read in more detail. I've whizzed through it now and it has piqued my interest. And if I don't read the whole thing now, I'm going to save it in papers, knowing that I've got it and knowing that next time we have a case to discuss around acute mesenteric ischemia or there's a teaching session on it, I know exactly where to find this. So I'm saving this PDF and I'm going to drag it into papers. And now it's imported. I can click on it and I can add some tags. Got gastrointestinal. I've got surgery. I've got to read because I want to read that in more detail. And I'm going to save that. So we've gone back to the spreadsheet. That was critical care. I've ticked that off. So now I'm happy I've reviewed all the intensive care, critical care journals that I like to look at for the month of January. I'm recording this in March, so I'm not up to date, but there's a part of my brain now that's satisfied, less restless and less paranoid that I've missed some important stuff, and I can then move on to look at the rest of the February journals. For shits and giggles, let's have a quick look at intensive care medicine now, because that's a lovely journal. There's great articles in that. And we'll look at February. So we've got a statement on dyspnea in ventilated patients from the European Society of Intensive Care Medicine. That looks very interesting. Open that in another tab. Something on very old critically ill patients. Don't think I'm going to read that now. Stuff on high and intermediate risk PE in the ICU. I might have a quick look at that. Mechanical circulatory support for cardiogenic shock. Meta-analysis of randomized controlled trials. I'm going to stick my neck out and say that isn't going to tell me anything I don't already know from existing literature. VTE and malignancy. Selective digestive decontamination. Someone saying we have to make a decision internationally on this 40-year-old controversy. I'm not going to be contributing to that decision today. So lots of interesting stuff in that one. The temptation is to read all of those, and if I was a full-time intensivist, I'd be quite happy to sit down somewhere comfortable and flick through that journal. But I have to be more selective, so I'm going to look at a couple of those papers and then tick off January. So here's the mechanically ventilated patients with dyspnea, a statement. I'm hoping there's some sort of infographic. There we are. There's some interesting stuff about suffering from dyspnea, stimulus in your respiratory system, afferents, but also other sources causing afferent traffic in the brain, which you will perceive driving you to breathe more, and how you process that cognitively affects sensation, can affect you emotionally, contributing to suffering, different kinds of stress that might manifest behaviorally, but the end result is dyspnea. And some patients can self-report dyspnea if they can talk or communicate with other modes, but some patients on ventilators won't be able to. So how do we observe them to see if they're experiencing dyspnea? So patients on ventilators can be feeling breathless and not be able to tell you. It could be occult and persistent dyspnea and contribute to post-traumatic psychological consequences. So this is obviously an extremely important topic which could contribute to the overall torture burden of patients in intensive care on ventilators. So this looks fascinating, and here are a nice little diagram showing if your ventilator settings are under assisting the patient or over assisting the patient, how that can manifest in terms of afferent signals and then efferent signals. Some stuff on air hunger there. And a reminder here that data from many studies suggest that the prevalence, the intensity, and the impact of dyspnea are all underestimated by caregivers when assessing ventilated patients. We don't ask patients, they can't self-report it, clinicians are underestimating it. Wow. So this is something I like to discover, a paper that opens my mind to a phenomenon or a concept that I either didn't know about or haven't given sufficient thought to in the past. And this is why reading journals, I think, makes you a better clinician and certainly a better educator, because this is something that I can now talk about and teach on ICU ward rounds, and so instill and expand this in the consciousness of the rest of my team, both nursing and medical. But what I want from this paper is a way of identifying markers of dyspnea in patients who can't self-report, and then a strategy for dealing with it. So some interventions to relieve dyspnea here. It's going to include reassuring patients, enhancing their sense of control, reducing non-respiratory stimuli of respiratory drive, like fever, acidosis, pain, or anemia. That's great alone, isn't it? A nice little set of modifiable factors that can help dyspnea that we should think about. There's 4 of them, so it would lend itself to a little acronym, wouldn't it? FAPA. Right, we'll come back to that. Great, some tips on optimizing ventilator settings, depending on what mode of ventilation they're getting. Oh, this looks great. I'm definitely going to read this one in full. Pharmacological and non-pharmacological interventions, as well as the ventilatory strategies. And we've got a summary of interventions here. This is the kind of thing I look for. A little infographic, diagram, or flow chart, or algorithm. So it's all here, isn't it? Let's get the full-size image. And what are we going to do? We're going to proactively look for dyspnea or any evidence of respiratory-related brain suffering. We're going to try and quantify that. And now we're going to relieve those non-respiratory stimuli we just mentioned: fever, acidosis, anxiety, pain. We're going to correct abnormal respiratory impedance so we can minimize airway resistance with suction, bronchodilators, so open up those narrow airways. That will reduce resistance, and then maximize compliance. How do we make the lungs less stiff overall? We can address atelectasis, we can decompress pneumothoraces, could treat pulmonary edema. Now we can adjust ventilator settings. Think about switching to pressure support, giving the patient some conscious control over their ventilation. We might need to increase inspiratory flow or the pressure support level to match patient demand. If the patient has intrinsic PEEP, so dynamic hyperinflation or air trapping, we might be able to offset that with some external PEEP, so they're not having to work hard on inspiration to overcome the high pressure within the alveoli to initiate the breath from the ventilator. Correct aggravated hypoxemia. I like that term. I'm going to have to look that up. I think I know what that means, but I'm going to read it. And then other non-pharmacological interventions like relaxing music, fresh air to the face can help dyspnea. Is there a fan we can use? And then the pharmacological treatment, low-dose opioids are good at relieving dyspnea and potentially an anxiolytic. That's some really nice stuff. There's a strategy right there. There's a nice diagram. I'm going to copy that image. I'm going to open Evernote, where I keep notes on everything, including clinical notes. I'm going to make a new note. I'm going to paste that in. I'll give it the title of the article. I'm going to download the PDF. I'm going to drag that PDF into Papers. So it's imported. I'm now going to add tags: ventilation, respiratory, guidelines. That's saved. And what I'm going to do now is I'm going to copy the formatted reference. So in my Evernote, I can put the reference. So if I have to quote this, that's the reference. And now I'm also going to copy the URL that will take me to this paper within my Papers app for when I want to read the full text if I'm referring to it from Evernote. I'm now going to tag this within Evernote, ventilation guideline, and I'm going to put this in my clinical notes notebook within Evernote, which is useful for referring to when I'm on the shop floor in the hospital or when I'm teaching. So the way this is going to work is when I'm on intensive care, I'll have a patient on a ventilator. I will remember this article. I'll pull out my smartphone, I'll open Evernote, and in my clinical notes notebook, I'll find this fantastic little flowchart here, and I can use that as a basis for teaching this concept to my team and in real time addressing these issues with a patient. I can share the article by clicking on this link, which will take me to the paper's full text PDF. And if any of the team want that paper, I can share it with them from there. This looks like such a worthwhile document. I'm going to share this on Twitter today as well and pay it forward because I learn so much from the people I follow on Twitter. The next article was high and intermediate risk pulmonary embolism in the ICU. Remember, we're looking at February issue of Intensive Care Medicine. There's this article on big PEs in the ICU. The reason I'm scanning this is I'm very interested in the medical management beyond thrombolysis of massive PE, how you can buy time for these patients in terms of hemodynamic support and offloading the RV. There's very little written on it, and in my view, not enough people think of that aspect of management when they're resuscitating a PE patient. So we've got a nice little diagram here. Let's see what this suggests. Remove the pulmonary artery obstruction, systemic fibrinolysis, or alternatively a catheter-directed approach or surgical embolectomy. Okay, so we want to remove the clot to decrease the RV afterload, and there's some risk of bleeding. We want to optimize oxygen delivery, and there's a caution here that invasive mechanical ventilation can worsen RV afterload. So these patients are at risk of arresting on induction and intubation and ventilation. Improve the RV function. So their drug of choice is dobutamine. Interestingly, a good alternative is milrinone, which has pulmonary artery vasodilation effects, but they haven't mentioned that here. Volume optimization. Consider volume loading and considering diuretics. And there's increasing evidence for the role of diuretics in acute RV dysfunction due to pulmonary embolism, as far as I understand it. Restoring systemic blood pressure. First line is noradrenaline. That's perfectly reasonable. I might think about vasopressin because it won't worsen pulmonary artery vasoconstriction, but they haven't mentioned that here. And then rescue therapy is VA ECMO, of course, being the rescue therapy of choice in hemodynamic collapse here. So this is okay and reflects mainstream thinking. I'm a bit disappointed there aren't more options to offload that RV, like inhaled nitric oxide, or if you don't have that nitric oxide donor, which is inhaled nebulized GTN. And so there's not a lot of out-of-the-box, small print, life-saving stuff that I like to read about, but I guess that's to be expected. Nevertheless, this is a nice little representation of some of the issues and how you might structure your approaches. So I quite like that diagram. That might be something I save and use. Nah, I don't think so. Oh, they have mentioned pulmonary vasodilators in the text and the corresponding lack of significant evidence base for their support. So they fleshed out the catecholamine strategy in the text, recommending noradrenaline or norepinephrine as the recommended drug and can be safely infused through a peripheral catheter, which we know. So I'm glad they've put that in. This is interesting. They say low to intermediate dose dobutamine was historically considered the preferred drug. In a porcine model of PE, it increased RV afterload and mechanical work at higher doses, and it may increase LV systolic function in an already normal or even hyperkinetic LV. So avoid higher doses. So you definitely don't want to be cranking that dobutamine high up. It can make things worse. They're asking if there's a role for inodilators such as levosimendan, but that's not evaluated. But of course, systemically, they can lower the systemic blood pressure, which limits their use. So why then are they not recommending milrinone, which has pulmonary vasodilation effects, and in its nebulized form, which offsets the systemic hypotension? Don't know why they don't mention that. And then vasopressin at low dose can potentially improve RV function for its advantageous effects on the pulmonary vasculature. I think the main reason is because it doesn't constrict the pulmonary vasculature. Specific role in PE patients of vasopressin remains to be tested. All right, so there's a fair brief overview of some of the literature in the text, but with insufficient evidence base to include it in their diagram. Fair enough, I guess, fair enough. All right, so that's not a bad paper as an overview of up-to-date approaches to big PEs. So I'm going to keep that free text. It's also got some nice diagrams in it, which are useful to include in teaching sessions. So that one is getting dragged into my papers library. So it's now been imported. I can tag it, and I've got a VTE tag for venous thromboembolism. There we go. So that was the February issue of Intensive Care Medicine. Tick, only 3 critical care journals to go before I've completed February. So you can see I'm spending a fair bit of time on this, but I'm getting through a lot. I'm getting an overview of what's in the literature. And if I do this once a month for a few hours, I feel on top. But that's just the critical care journals. I also go through the pediatric journals, general and cardiology journals, emergency medicine and resuscitation journals, anesthesia and pre-hospital emergency medicine journals. And as an example, if I open my Google spreadsheet for there, you can see how far I've got with anesthesia and pre-hospital emergency medicine. And if I show you the emergency medicine and resus journals, finished January, haven't got much of February done yet. And as I said, I'm recording this in March. So that's how I try to keep up to date with the primary literature. It's a bit mad. It's the most efficient way of not missing stuff I've managed to get to over the years. I'm hoping that AI in the near future will help me get more efficient at this. But this is how I learn. This is how I stay up to date. This is how I open my mind to new concepts and new approaches. And I let these things simmer in my brain, and I try and talk about them the next time I'm with my colleagues or with my trainees. And I want to do some off-the-cuff teaching or ask what my colleagues think about their approaches to things are. Repetition is the mother of skill. So looking at this once and filing it away in my papers library isn't learning. So on top of this, there also has to be a review process, a repetition process, a revisiting process to embed it in my brain. I don't know if any of this is useful to you viewing it. It's probably vaguely interesting to see how someone else tries to tackle this. If you've got a better way or suggestions, absolutely let me know through the comments. I'll put relevant links in the description to some of the resources I use. And as always, thank you very much for watching.